So good morning, everybody. Thank you for joining us for our first event of a monthly series we've created for SunCloud Health. This is our Child and Adolescent Professional Development Series. I'm Renee Bach. I'm a member of the outreach team here at SunCloud. And for those who aren't familiar with us, we provide integrated person-centered treatment with residential PHP and IOP programs in the Chicago area. We serve adolescents and adults with a special emphasis on those who struggle with complex co-occurring disorders. If you are interested in learning any more about us or collaborating with our team, there'll be a couple of contacts listed at the end of our presentation today. They're happy to help if you reach out to them. Our goal is to support you all as community partners with monthly educational events to support your practice. Today, our speaker is Dr. Alexander Chevalier. He is the medical director of SunCloud Health's Child and Adolescent Psychiatry Services. He is a board-certified adult, child, and adolescent psychiatrist who completed his medical training at the University of Wisconsin, followed by his adult residency and child adolescent fellowship at the University of Illinois in Chicago. So without taking up any more of our time this morning, I'm going to hand it over to Dr. Chevalier and let him begin today's event.
Thank you, Renee. Appreciate that. Thanks everybody for joining us here early this morning. We actually did one of these talks in November at noon, so let us know if you prefer the early morning talks or the noon talks. We're trying to find out the best way to serve you. Just by way of context here, this talk's going to be targeted towards folks in the adolescent mental health space, specifically individuals working at schools, although certainly if you're working in the community as well, 90% of it will be applicable to you, if not 95. So I will be happy to take any questions that you have at the conclusion of our talk. We're going to go pretty fast here so that we have some time remaining at the end of the day for questions. Thank you all again for joining us so early today. So the topic today is about diagnosis of pediatric bipolar disorder. I'm trying to separate out some of the facts and myths, and unfortunately the answer is still going to be murky at the end, but hopefully a crystal clear version of murky. So we're going to talk a little bit about the actual diagnosis, the course of pediatric bipolar disorder, what its comorbidities and impairments look like, as well as a little bit about how it's thought to come about, treatment for it, and implications for school mental health workers. Just cover that. So there'll be a few quotes here and there from famous individuals who have been known to have bipolar disorder. I would wager a guess that most of the people in this crowd are going to have a pretty good understanding of what actual bipolar disorder is, but probably the single least understood diagnosis in all of psychiatry. And so I do like to include a few quotes here and there. This is by Sylvia Plath about her experiences, one of the more famous individuals with bipolar disorder. All right. So starting with diagnosis, just to give you some way of background, when you're thinking about mood states or affective states, what we're thinking about here are kind of a normal balanced mood that you're seeing in the middle of this. Moods that are, abnormally elevated in this mild mania that we call hypomania, and then severely elevated in severe mania. And you can contrast that for individuals that you've encountered that might have more mild to moderate depression or dysthymia. Probably falls in this range, kind of mild depression here, moderate depression here, and then severe depression at the bottom. Right. Thinking about what makes pediatric bipolar disorder so difficult to identify, is that there's more severe affective dysregulation, higher levels of agitation and aggression. And compared to adults, children have more mixed presentations. We'll talk about what that means. They have a more chronic course, they have worse responses, and they have higher comorbidity. And so, if you think about anybody who spent a lot of time around kids, you're knowing that there's going to be a significant amount of things like affective dysregulation, things like agitation and aggression. Those are stances that kids are just more likely to be in than adults. And so this is part of the reason why this gets more complicated, and we'll touch on a little bit more. The other problem in pediatric bipolar disorder is that some of the symptoms cross over with other disorders that are very common in childhood and adolescence, namely ADHD, oppositional defiant disorder, in some cases depression, and these mixed states. And so that can complicate things further. The treatment is very different for bipolar disorder than unipolar depression, and so being able to identify the diagnosis is extremely important from a pharmacologic intervention standpoint, and certainly the schools might be the first case that place that these symptoms are presenting. So if you think about adult classic bipolar disorder, and again, I know this is old hash for most of you, but just to do a brief overview, bipolar 1 disorder is somebody who's had at least one manic or mixed manic episode. They may or may not have had major depressive disorder episodes. Approximately 75% of people with bipolar 1 disorder do have depressive episodes, which is why it's called bipolar or manic depression. But the true diagnostic criteria requires only the mania side of the mood state. Certainly individuals with bipolar 1 disorder have psychotic symptoms at a pretty regular rate when they're manic. It's roughly 50% of people with bipolar 1 disorder when they're manic experience some psychotic symptoms. And they may also have other modifiers on those mood states, like anxious mood states, mixed mood states, rapid cycling mood states, the other things that you'll see in major depressive disorder with peripartal onset or seasonal pattern. Peripartum bipolar disorder being a very scary time for women who deliver and have bipolar 1 disorder, but far beyond the scope of our talk today. And then, of course, we rate these things now in DSM-5 with mild, moderate, and severe based on the number of symptoms and the amount of impairment. In contrast, bipolar 2 disorder is an individual who's had now, in this case, both a hypomanic episode and one or more major depressive episodes. For whatever reason, well, I could tell you the reason, but it's a long story. You must have had both the high and the low, but this type of individual cannot have had any full manic episodes, any manic episodes requiring hospitalization or causing severe impairment. And cyclothymia, something pretty rare to see, but individuals whose mood states fluctuate between hypomanic and dysthymic mood states without having the real highs and the real lows, almost not even worth thinking about, but does need to be included in here. And then, of course, we have the unspecified bipolar disorder, bucket for people who do have clear features of bipolar disorder, but do not meet the full criteria. We'll talk a little bit about that as we're going forward. So thinking about what makes the actual criteria for a manic episode, there must be a period of time lasting 1 week with this abnormally and persistently elevated, expansive, or irritable mood. We're going to talk about this a bit more, but in the case of adolescents, the irritable part is the thing to focus in on. They must have 3 of the 7 symptoms for when mood is irritable. This inflated self-esteem or grandiosity, a decreased need for sleep, and that's a dramatically decreased need for sleep, talking about a few hours of sleep a night at the most. Pressured speech, somebody talking so much that it's hard to get a word in. It's very difficult to interrupt them. Flight of ideas or racing thoughts. So this is going from a unrelated topic to unrelated topic to unrelated topic to unrelated topic. It's pretty striking when you get to hear somebody in that space. A severe level of distractibility that's out of character for them at baseline. We'll talk about how that compares to ADHD. A significant increase in motor activity or working on goal-directed activities. And typically this is somebody who, say, like in the middle of the night will have their kid be like cleaning and working on homework and starting their new investment thing and working on an art project, but may not complete any of the specific tasks itself. And then lastly, these overvalued pursuit of hedonic interests, so substance use, sex, gambling, other things that have these kind of basic dopamine activating activities that we come to think of as being hedonic. And so these episodes have to cause severe functional impairment, necessitate hospitalization, or have psychotic features in order to classify, in addition to meeting those 3 or 4 criteria on the last page. And even if this does occur in the setting of antidepressant treatment, we do now still call it mania. It's just a small tidbit that changed for any of you who's been in the space for a long time. We didn't prior to the past 10, 12 years, but now we know that when folks look manic on just an antidepressant, but not substances of abuse or misuse, that those are still characterized as bipolar disorder. All right, so when we're thinking about what this is going to look like at school, you might see kids who look, just very different than they otherwise had looked in the past. Somebody, for example, laughing hysterically for 30 minutes after a funny comment by somebody, as opposed to somebody laughing for 30 seconds after a funny comment. And this type of, silliness is just very out of the normal or, typical thing that you're encountering with the other kids that you're around. The irritability, for example, again, is just going to be this severe level of rage that's going to be completely inappropriate to the context of what's going on. So like a small reprimand or some negative thing happening results in, a giant tantrum, throwing objects, damaging things, hurling obscenities, those kind of things. Then inflated self-esteem or grandiosity. would be like a kid telling, other kids that they have special powers, that they're related to, these powerful people, things that are relatively outlandish. In this case, somebody telling you that you can fly would fall into the very outlandish range of things. Again, the decreased need for sleep is pretty stark and is one of the hallmark features of bipolar disorder. So kids who are going from sleeping 7, 8 hours a day, but now only sleeping 3 hours, but then their energy level is very high, despite the fact that they're sleeping very little, is one of the clearest signs that you can ever have that you're dealing with bipolar disorder. Normal mortals, like myself and likely many of you are not able to sleep only a few hours at night and have this very high level of energy. It's a virtually impossible thing to create for somebody who has normal brain physiology. The increased speech, again, is going to be usually typically loud, and it's that uninterruptible or pressured rate to it, where it just goes on and on and on. And when you try to interrupt, you just kind of get run right over. And that's a pretty telling sign, as well as this, jumping from idea to idea to idea to idea. So the individual descriptions and things that they're saying might sound outlandish, but they're still followable. It's not like they're just having a word salad of words. They might be talking about the price and tea in China to like their favorite Pokemon, to what's going on with like, the Middle East or whatever. I mean, it's just going to be jumping all over, but each individual thing that they're talking about, is still sensical, and it's something that you can follow briefly if you're paying good attention, at least. Again, that severe distractibility, so way beyond what somebody would normally otherwise look like from a distractibility standpoint. You have a kid who's normally able to pay attention, and all of a sudden they're not following along with anything. That increase in goal-directed behaviors that we're talking about. So a kid who's just like working on things, trying to build something, creating another project, trying to clean something, but then not actually finishing any of those things during the day. And then that hedonic pursuit, like a kid who's all of a sudden starting to make sexual comments that was not otherwise doing any of that, like using substances in the middle of class. There could be different sexual behaviors that might emerge in very inappropriate manners. Those would all be signs of that as well. This is another quote. Life feels like it is supercharged with possibility. Ordinary activities are extraordinary. Become the Energizer Bunny in a supercharger. Why does everybody else need so much sleep? I wonder. Hours pass like minutes, minutes like seconds. If I sleep, it is briefly, and I awake refreshed, thinking this is going to be the best day of my life. Sounds pretty exciting. Hypomanic criteria are going to be the same symptoms as manic. With the biggest difference, well, the only difference is as follows. It's a 4-day requirement instead of a 7-day requirement. Impairment does not need to be severe, does not require hospitalization, psychosis, or severe functional impairment. In some cases, there might not be impairments at all. There are individuals that have hypomania that while they're hypomanic, they are actually just profoundly productive, which is one of the tricks in treating it. But the kind of flip side of hypomania, as we talked about, is that it leads to major depressive episodes. That's why bipolar 2, again, requires both hypomania and major depressive episodes. And the crash from hypomania into depression is a very scary and high-risk time from a safety perspective. So just to real quickly go over in major depressive disorder, when we're thinking about adolescents, the exact same criteria that everybody's used to for this, symptoms have to last 2 weeks, the SIGI CAPS things, I know all you know this. Just as a brief reminder, in children and adolescents, the mood state can be irritable rather than sad. And in fact, it often is. And that adds to the complication of bipolar disorder diagnoses, because that chronic irritable mood state can be present in both depression and in bipolar disorder, which is different than it is in adults, and is a unique finding to dealing with affective disorders in the child and adolescent space. So again, CE caps, again, I'm not going to waste you guys' time with that. I know you're aware of that, and you know the criteria for major depressive disorder. Again, real quickly here, the things you're looking for, kids that are down, irritable, cranky in ways that they weren't in the past, sad for reasons that are not, obvious, not like a reaction to being bullied or getting a bad test score, but just very sad all the time. No longer showing interest in extracurriculars, I think, is one of the big ones I often see, where kids are dropping onto things that they were really good at and really enjoyed doing. Significant changes in their body mass, where they get much heavier or much thinner than they had been in the past. Of course, a significant risk for eating disorder as well, but also a significant risk for depression. Changes in sleep. Typically, if you're depressed, kids will sleep more. Some kids will sleep less, but they will look very groggy, struggling with concentration, struggling to complete tasks, low energy, in contrast to the kids in hypomanic or manic states. You can still see kids that are very fidgety, but typically, actions are going to be more slowed down, like you're moving through quicksand. And getting complaints of feeling tired and not being able to keep up with, say, physical education. They get very drained after 5 minutes of gym class, and they weren't before. There's a broad number of things that can be, but certainly depression is one of the more common. And then issues with feeling worthless, hopeless, talking about how things are never going to get better, that nobody likes them, that everybody's against them, kind of classic depressive thinking. And then again, as we talked about, the problems of concentration, which are present in both of those positive and negative mood states. The hopelessness that I just mentioned, and of course, the thing that we're all the most worried about these days is the recurrent thoughts of death and suicide. As a result of some of the hopelessness, that low energy, that low mood, the brain is able to kind of trick you into thinking that things are not going to get better, and suicide can be a natural, suicidal thoughts can be a natural result of that, and a part and parcel with being depressed. Roughly 75% of people with clinical depression deal with suicidal thoughts at some point in time. So we're thinking back to kind of the mood states and how they can fluctuate between them. Classically, in bipolar disorder, the average bipolar case without any modification is having 3 or less mood fluctuations a year, and the average, like the median across people, would probably be 0 or 1, probably 1. Right, so this is not a disorder in which people are switching between them rapidly when you're thinking about the adult world. And this is one of those big, areas where people misunderstand. God, doc, I got bipolar disorder. I was feeling so bad, and then I felt so good 3 minutes later, and I felt so terrible 10 minutes later, and so great, 8 minutes later. And this is very clearly not bipolar disorder, right? These depressive manic episodes, they typically last for several weeks to months if untreated. They can last for years, is not uncommon, particularly in the depression case, if untreated. So these are not rapidly occurring things. We do have a rapid cycling specifier for individuals that have 4 or more episodes in a year between depression and mania. And that's considered, of course, to be a significant exception rather than the rule in bipolar, which is why it's a different specifier. Right. Now, when you're thinking about treatments for the team here, children who experience bipolar disorder symptoms, but that do not meet the criteria for any of the diagnoses that we had, would qualify under other specified bipolar and related disorders. And this is where I want to start talking about a few of the things that can be misconstrued with that. One of the more common ones, this newer diagnosis of DMDD, disruptive mood dysregulation disorder. DMDD is, in contrast to what we were just talking about here, a daily irritability and problem with affective regulation. Individuals with DMDD, their mood charts, if you were to chart it out, look like sawtooth lines going up and down. And that's in contrast, again, to somebody with, bipolar disorder, where they should be, longer periods of time up and down. DMDD is really just a pervasive chronic problem with affective regulation, can have that significant irritability and anger, but is not associated, with the things like the grandiosity, the diminished need for sleep, those types of changes that are associated in the different affective states. Other differential diagnoses and things to be considering when you're thinking about bipolar 1 disorder, normal mood swings being one of them. Certainly being a child or adolescent is associated with having your mood not be under perfect control at all periods of time, which anybody could tell you who spends much time with children. So that's certainly a big one. And then definitely people with, bipolar 2 versus bipolar 1, major depressive disorder, again, has some features actually of bipolar disorder, with problems with concentration, problems with sleep in some cases. And then some of the things that are less common would be in this chronic psychotic range, like schizoaffective or schizophrenia. The likelihood of those occurring in children is very, very low, but that certainly does happen in some teens and in very, very rare children. And then one of the biggest ones is going to be substance-induced mood changes. This is actually pretty common these days. We see a lot of people who present in a way that looks to be bipolar, can actually occur as a result of cannabis use, can certainly occur as a result of amphetamine, cocaine use, any of the psychostimulants and quote unquote uppers have a pretty good chance of generating that response. Similar thing for bipolar 2 with the other diagnoses that you could be thinking of. Here you start to see a little bit more of ADHD symptoms looking similar to what you might expect to see. So we'll talk a little bit about that as we're going forward. Cyclothymia, we always just skip but include for sake of it existing. All right, so now we're going to get into the kind of more exciting part of the discussion, this controversial area of what it is to be in this pediatric bipolar disorder age range, and what does that mean? Right. So we use different terms to define these things in the pediatric bipolar literature. There's this concept of an ultra-rapid cycler, so somebody who has episodes that last for several hours to days, but less than 4 days required under hypomania. And then there's this idea of ultradian cycling, which is somebody whose episodes last for minutes to hours, and they have a chronic kind of baseline mania. I will say the ultradian cycling is a pretty, niche view in the field. I think the average pediatrician, child adolescent psychiatrist is probably not overwhelmed by the veracity of that diagnosis. There's some very famous scholars in the bipolar space who've kind of presented that, and it's a very controversial area as to whether or not that exists. I think there's certainly more consensus that there are kids that do have bipolar disorder where the episodes last for several hours, maybe 6, 8, 10, 12 hours, and more commonly in the span of a couple of days, and otherwise meet the full criteria and look more like this ultra rapid cycling. And that already gets into this very complicated space of kind of what is this? How do we diagnose this? How do we make the diagnosis? And then what do we do? But I do want to, just for completeness sake, let you know that this is certainly an area of ongoing controversy as whether or not this ultradian cycling actually exists. Are those kids better identified as DMDD or other diagnoses that go on to represent why they're having that? In some cases, for example, kids may have autism spectrum disorders and be, irritable with the environment around them and people not understanding them every single day, but they get called, bipolar disorder. There are also a host of other things that can be considered there. So this type of diagnostic criteria is why this area has the controversy that it does. Again, so we're thinking about adults, the average length of episodes lasting for months at a time. There's usually clear onset and offset. And actually, the diagnosis is pretty straightforward, if I'm being honest, for my adult colleagues out there. If you can get the good history and get the correct collateral and actually find out the information, right? In kids, it's just not that straightforward. Kids are going to have these higher rates of cycling. They may cycle faster than the adults are even definitionally allowed to cycle. They have lower rates of responsiveness to recovery. And so they can have this more chronic kind of presentation with what's going on, particularly prior to the onset of medical interventions. Right. So again, in adolescence, mania is frequently associated with this mood lability, but also psychosis, depression. That tends to be more obvious once you have the psychotic symptoms. That's the case where I see kids being pretty accurately diagnosed with bipolar disorder, although certainly kids with major depressive disorder can be psychotic as a result of their mood disorders. I see people kind of reach more for it once they see that clear psychosis. One of the things to be thinking about with adolescents is, unfortunately, the bipolar disorder presentations, the prognosis tends to be worse the younger that you are. And a lot of that is because the course of the illness tends to be more chronic. In prepubertal children, we see this kind of mania as being a very irritable presentation, and it tends to be very chronic in younger kids. So again, this is going to look back towards are they having these shifts that meet criteria for these several hour periods, multiple day periods, and then kind of what you do about it. A lot of times these kids are kind of felt to be like in the ADHD space, DMDD space, or kind of the bad kid, ODD, conduct disorder space. But there are certainly cases where some of those young children really do have this more chronic pediatric bipolar disorder, which you find out when you give them medications and see dramatic changes in the personality, which would not occur with those other conditions. So again, thinking about some of these unique features that you're going to find in pediatric bipolar disorder, again, more chronicity, longer episodes, higher rates of mixed episodes and faster cycling. Mixed episodes, and I forgot to bring this up before, are times where you have elements of both depression and mania at the same time. It's a very confusing state to see and witness, but also to be in, because there are individuals that may, be sleeping very little and have lots of energy, but also be telling you about how terrible they feel and how awful the world is, but saying that really fast and rapidly. It can be a bit of a jarring experience just to listen to somebody in that state, much less be the person who's actually in that state and experiencing those very distressing symptoms. And that occurs more frequently in the pediatric age range. Again, this irritability is going to be an almost constant of what you see when you're talking about, especially the younger kids with pediatric bipolar disorder. If they're happy as a clam, maybe they're the unicorn that has that more euphoric mania. But typically, you're really going to see it present with a severe irritability. And there is, unfortunately, we're going to get into this now with comorbidities here, a very, very high rate of ADHD amongst these individuals as well, which makes it harder to kind of look at the differences between chronic and then mood changed states. All right, so if we're thinking about, again, kind of what the demographics are going to be of kids who are coming on with pediatric bipolar disorder, in childhood, males are two to one more likely than females. By the time you reach adolescence, it's a 1-to-1 split. Chronically, over 50% of kids who are diagnosed with bipolar disorder are going to have that chronic course. In adolescence, it's only 1 in 4. And so conversely, that episodic course is going to be, a little under half in childhood and 3/4 of adolescence, where it's going to be looking more like an adult space. The episodes may go a little bit quicker, but they'll at least be fully episodic when you have adolescent onset the majority of the time. And then again, here, this ADHD comorbidity, very, very high in childhood, normal rate by the time you have adolescence. And then again, here we see this ODD diagnosis that gets thrown around quite a bit. Oftentimes, that's just going to relate to kind of the changes in that chronic irritability, that high energy level that you're seeing in kids in the pediatric age range that have bipolar disorder. So if you take a look at what symptoms get kids sent to see child adolescent psychiatrists, if you take a look for the specific age range of 3 to 7, you'll find that almost 90% of kids are referred for aggression and irritability, with sleep disturbances making up the second biggest bulk, which is almost 2/3 of kids. And I can tell you, having done 3 years of outpatient practice, this is pretty spot on for the 3 to 7-year-old age range. These are the main kind of conditions that we're dealing with in child adolescent psychiatry in this range. And of course, there are many conditions that can cause this, but one of the ones, and certainly the topical one today, is bipolar spectrum disorder. So ways that this gets talked about in the field are this kind of idea between the narrow phenotype and kind of the broad phenotype. And this is, again, this very ongoing controversial area of pediatric psychiatry. That narrow phenotype or narrow band bipolar disorder means the exact criteria that you see in adults are the same criteria that we would hold kids to, hypomania 4 days, full mania 7 days, the exact criteria, but just it is what it is. And in adolescence, there's a good number of adolescents who do meet that criteria, as we mentioned, and is relatively straightforward. As we unfortunately also know, kids are not just adults with tiny bodies, right? And they have different brains, different stages of neurodevelopment, and things are actually different swirling around up in their noggins than it is for you and I. And so the idea that everything in adult psychiatry should just be ported down to child psychiatry on a one-to-one basis, be the exact same, has been kind of the standard. Part of that is because adult psychiatrists, frankly, make the DSM, and there's relatively little input from child and adolescent psychiatrists, although that's increased, I think, in more recent times. We do not hold the power in the field, I will say, is certainly the case. And so if you take a look at the DSM, you'll see that there's almost a difference in criteria for diagnoses for basically anything in adulthood versus for kids. And so this is one of the areas where prominent pediatric psychiatry bipolar scholars have pushed back and said, there's probably something to what's going on with these kids. And it probably is the case that they are going to have these more rapid changes in their mood as a result of where they're at in neurodevelopment and how that's intersecting with the disorder that they have. And it is going to look different than it does in adulthood, like we talked about with those faster cyclings, the more irritable mood states. And then, of course, this idea that, if kids look to be this, don't meet the full criteria, you can always use this kind of other specified bipolar disorder diagnosis, and that's a reasonable place to be. Right. So, these are, when you're taking a look at pediatric bipolar disorder, kind of the range of symptoms that you kind of want to look for. I know we've covered a lot of these already, but just the things that are most common. And again, I think that sleep-wake cycle is one of the best places to cut your teeth. If you're ever getting a consistent history of a kid sleeping for only a few hours at night, not using any substances, and coming in with a very high energy state, it's a pretty big slam dunk. But of course, the difficulties in the kids who don't all fall into that category, about 3/4 are going to have that significant change in the sleep-wake cycles, but that does leave 25% that are going to be much more complicated to figure out and diagnose. Okay, so appreciate everybody for hanging in there as we're moving fast. I'm going to talk a little bit about some of the considerations to think about for individuals with bipolar disorder that are present at school. And then after that, like I said, I'm going to make sure that we have some time to answer all your questions. So feel free to throw them into the chat and I will get to all of them, or as many as time allows, as we're finishing up here. Okay, so sorry, we're on comorbidity. I apologize. So we'll do comorbidity now and then get to the school part next. So comorbid disabilities, we talked about one of the most common being ADHD, oppositional defiant disorder, conduct disorder, anxiety disorder is actually relatively common, and then certainly substance use disorders are very common in this population. As I already mentioned, there's this inherent drive during mania for hedonic pleasure and more recklessness that occurs, and that in and of itself leads to higher substance use disorders. There's also some research that's been done that shows kind of how the reward circuits fire in kids that have bipolar disorder, independent of whether or not they're manic, leads them to more substance use. Actually, Manny Pavlori, a mentor of mine, who's credited on a lot of these slides, has done some of that research in the decades that have passed. Right. So if you're thinking about ADHD compared to bipolar disorder, one of the things that's probably pretty obvious but is worth thinking about is that there's going to be times where kids with bipolar disorder are just really on and they're really talking a mile a minute, and that feels qualitatively different than how it has otherwise felt when you've talked to that individual. Now, certainly kids with ADHD may come and go, but if you've been around people with untreated ADHD for much time, you know that there's sometimes a pretty pervasive. ADHD is not like a thing that turns on one day and is off for a week and then is on for another week. All right, if you got a kid like that, ADHD is very unlikely to be the only pathology that's going on. When we have patients that have ADHD in treatment and the treatment team's talking about them, every single person in the treatment team is like, oh yeah, like I could tell that kid's got ADHD, particularly for the kids that have that the style of speech and kind of jumping around and struggling with their concentration, but still talk a lot, have strong social skills, and are kind of giving you all sorts of things that are going through their heads, right? So that type of daily, distractibility, talking excessively, being on the go is really consistent with ADHD, and a lot of us have a pretty good idea what that looks like. And again, in contrast to bipolar disorder, you should see shifts in that. So it should not be the same presentation every day. And even potentially, if you're talking about a kid in the same day, first hour teacher and eighth hour teacher may have a different experience, with that kid. And that would give you some kind of clue. And certainly if, 1 week ago, they looked much different than they look this week, they look much different than they look next month, that's going to be a real good idea that you're thinking more in the bipolar space and less in the ADHD space. And then again, some of the other things I think are pretty apparent. Like there's no such thing as like grandiosity associated with ADHD. Although I do actually find that some ADHD kids can feel a little bit that way just because they're telling you exactly what's going through their head. So it's not quite as cut and dry as that, but there's certainly nothing where it's in the realm of like fantastical thinking or being related to folks that are not related to or things like that. Kids with ADHD do not have a decreased need for sleep. They may sleep less because they have problems sleeping at night, but they're going to suffer when they don't sleep at night, and they're going to have worse symptoms. They're going to be concentrating less well and have less energy as a typical rule. And then again, with the age of onset, you're typically going to see ADHD symptoms present very early in life. By DSM diagnosis, they technically have to be present before the age of 12. But if you are a scholar of the DSM, you'll know that ADHD previously had to have symptoms present before the age of 7. The only reason it was changed to 12 is because they were finding there were a number of kids who just weren't being identified, but probably had the symptoms then anyway, and we didn't want to exclude them from an ADHD diagnosis. So if you think about it, and somebody's around, good teachers, has attentive folks in their life, really ADHD symptoms should be present by early childhood. If you're thinking about developmental differences, certainly, like I just said, with children versus adolescents, the ADHD rates, adolescents are going to have high rates of substance abuse for sure across the board. Of course, adolescents are always going to have high rates of substance use than children, but the risk of substance abuse substance use disorders is almost 9 times higher in adolescent onset bipolar disorder than childhood onset bipolar disorder. Part of this might be a bidirectional effect because individuals may be using substances, and that may bring out the bipolar symptoms earlier on. We already know that phenomenon exists for sure with cannabis and schizophrenia or chronic psychotic disorders. There's some risk that cannabis and other substances may do that in bipolar disorder as well. Talking about the associated impairments, one of the big concerns with bipolar disorder is the prevalence of suicide attempts. It has historically been the case that at various points in time, depending on how you slice the data, bipolar disorder was actually the single highest lethal psychiatric disorder. Most of the time, that's not the case anymore. Eating disorders, compete with it. And certainly nowadays, unfortunately, opioid use disorders are certainly going to be at the very top of that list. But the rates of suicidality are very high in bipolar disorder, even higher than unipolar disorder. And so that's certainly one of the biggest concerns associated with this illness. What happens for individuals who are feeling really good at the top of the world is that they inevitably stop being in manic or hypomanic states. And it is not uncommon for people to go from that mania or hypomania straight into clinical depression, as opposed to like having an elevator stop at the neutral mood floor. It does happen for some individuals, but it is very commonly the case that you go from being real high to real low. If you just think about the delta, if you're going along, having a normal day, you get depressed, it's awful. One of the worst things you can imagine in the world. If you're going along and feel like you're on top of the world and have godlike powers and can do anything you want and are the most amazing person in the world, and then you hit depression, awful can't even begin to describe what that experience is like, which is part of the reason why you see this level of suicidality. In addition, in pediatric bipolar disorder, we know that there's a lot of cognitive deficits that are associated with this disorder. So problems with executive functioning, attention memory, sensory motor integration, nonverbal problem solving, and even some specific academic deficits in math are characteristic of kids that have bipolar disorder. And these deficits are there even when they're not in manic or depressive states. So even when they're euthymic, they still have carryover differences in their brain. If you think about adult bipolar disorder, people will tell you kind of the times that they're not high, not low, they're normal, is kind of how we think about it. But certainly, and I'm not as familiar with adult research, I apologize. Certainly in the pediatric range, we know that they're not normal. There's still persistent deficits that exist even when they're euthymic. There's often pretty significant psychosocial deficits. People, have a hard time being around individuals who struggle with bipolar disorder because they themselves are struggling with their emotional regulation. They're typically very irritable. They can be very impulsive. So it can be difficult for them. Relationships both with peers and family members. Certainly just their understanding of other people's emotions is impacted by the illness. It's kind of fascinating. They've done like facial recognition studies with kids that have bipolar disorder, and they do not perform the same as kids who do not have bipolar disorder. And of course, this can lead to issues with self-esteem. And then, of course, the impulse control problems are part and parcel to mania, but can also be present even in a euthymic state, and is certainly exacerbated significantly by the kids who then go on to use substances, which affects their baseline impulse control. All right. So, as far as what causes bipolar disorder is concerned, like much of this, it's going to be a complex story. We do know a little bit more about bipolar disorder than some others. When you take a look at twin studies, monozygotic twins have like a roughly 0.7 correspondence. This one's saying 0.67. It depends on where you look. In some cases, it's been even higher. In other cases, a little bit lower, but it's a pretty significant, genetic component. If you keep in mind with heritability, you always want to take the exponent, so it's R squared of that to know what percentage of the variability is created by that specific variable. So if you take 0.7 and square it, that's roughly 50% of the variability in the presentation is related to genetics alone. And I think most people would say that that's about right from a bipolar disorder perspective. Certainly, if you have first-degree relatives with bipolar disorder or schizophrenia, they actually carry almost the same genetic risk package. So either of those disorders in a first-degree relative, that dramatically increases your baseline rates. Roughly goes from a little over 1% to closer to 8, 9, 10%. If you have a first-degree relative with either of those disorders, second-degree relatives will take you from about 1% to 2%. So it's still a significant increase, but the absolute magnitude is much less. So the environment is certainly playing some role, and then of course other things that could be going on, epigenetics, other infections, early life interactions, things like that, that we never seem to be able to fully square away. Neuroanatomically, there are certainly differences in kids' brains. These are some of the ones that Dr. Pavlori has looked at in the past, changes and decreases in hippocampal volume, smaller amygdalas, changes in the white matter that can be seen between MRI and in some of these later cases, fMRI studies, reductions in the DLPFC. There's certainly things that just look different about kids' brains that have bipolar disorder. And if you spend time with kids with bipolar disorder, you can kind of tell like the brain is set up differently. So this isn't a huge shock. But for anybody who thinks that psychiatry is not real or that these kids are somehow just making things up, there's very compelling research to suggest that these brains of kids with bipolar disorder do not look the same as other kids' brains. Unfortunately, the diagnostic clarity with these studies to say like, hey, can we just throw you into an MRI, which is a very safe, albeit a bit expensive procedure, is still low. And so this was kind of thought to be like the next holy grail in psychiatry 2 decades ago, when this work was being done, of saying like, can we actually just for sure figure this out by putting kids into scanners? And although on the aggregate, if you take a look at 1,000 kids, you're going to see these differences. Not every kid has each of the differences, and that leads to the complexity of things. Okay, so again, lifetime prevalence, roughly 1% for 14 to 18-year-olds, but those that have subsyndromal symptoms, so elements of bipolar disorder, much, much higher at roughly 6%. Age of onset, roughly 10 to 12 years old. When you're taking a look at pediatric bipolar disorder, and the first episode is usually depression. And so keep in mind, when we say age of onset, that's typically when they were first depressed, but then that kid may go on to have their first hypomanic or manic episodes years later. And sometimes it's because we give them medications that provoke them just because we can't know that they have bipolar disorder. And other times it's just the natural course of the illness. So again, from a prognostic standpoint, bipolar disorder, certainly the real deal with concern. As I mentioned, they have very high rates of suicide, or individuals suffering with bipolar disorder have very high rates of suicide. They also have, significant impairments in school, their ability to graduate high school, interpersonal relationships, hospitalizations, legal difficulties, substance use difficulties, and it's really a chronic brain disorder in children that you can't cure it, you can't grow out of it, although you can certainly treat it with medications. And our ability to treat it with medications has actually evolved significantly in the past 15 years, which is wonderful. I'll talk about that very briefly. So again, prognostic-wise, bipolar 1 disorder is going to be the most severe, strongest episodes. Bipolar 2 disorder are going to be more chronic episodes, and it can be a little bit harder to diagnose, which can make it difficult. And certainly the swings from hypomania to clinical depression still very severe and very high risk from a suicide perspective. And then, of course, the majority of the kids that we're talking about are not going to meet the full criteria, are going to be maybe potentially in that ultra-rapid ultradian cycling range, and we're going to call them something more like an other specified bipolar disorder or unspecified bipolar disorder, if you ever see that on somebody's chart. So like I said, briefly to talk about treatment, when it comes to treating bipolar depression, there's certainly medications that work for that. Lamictal, lithium should be on that list, are pretty effective mood stabilizers for helping the depressive phase of things. In some cases, we use antidepressants, and in some cases we don't. It's a little bit of a complicated area. It also depends on what other medications they're taking, whether it's bipolar 2 versus bipolar 1 disorder. So there's a lot of controversy, unfortunately, still in the treatment of bipolar depression, and it really is a tricky area to say the least. From a mania perspective, we are very good, actually, pharmacologically at treating mania. There's a virtually unlimited number of agents these days that are highly effective at blocking mania. And so, nowadays the thing was not just like, can you treat it, but can you treat it with a good side effect profile? And I think in most cases, the answer to that is really yes. These days, lithium, Depakote, Trileptal from the mood stabilizer categories, all effective medications for mania. Many and almost all of the atypical antipsychotics and even first generation antipsychotics have very strong anti-manic effects. The ones that you typically see used are going to be Seroquel and Latuda, and then to a lesser extent Abilify. And that's because Seroquel and Latuda are both very effective for treating bipolar depression as well. They may be some of the most effective agents out there. And so they're helping to cover you on both the mania and the depressive side of things. Seroquel being the most effective of all the agents we have, potentially with the only other contestant in that category being lithium. So for kids who have really severe or even just regular bipolar disorder, which is a very severe disorder. It's not uncommon to see kids being prescribed a Seroquel lithium, particularly by doctors who know what they're doing and are willing to take on some of these higher risk medicines to change somebody's life. And so these medicines really give us a big armament in being able to improve symptomatology in kids. And again, just the formal recap of that, the mania portion of things much easier to treat. The bipolar depressive side of things is the hardest part of the illness for sure to treat. And that's why the understanding around the medicines that can treat bipolar depression, largely lithium, Seroquel, and Latuda have been, and Lamictal, have been a real game changer. From a therapy perspective, there's been a lot of work on therapy done, Rainbow program being a really cool one done for youth, and certainly rhythm therapies that have been adopted from adult research down into the pediatric age range can be wonderful as well. Circadian rhythm plays a much larger role in psychopathology for individuals with bipolar disorder than people who do not have bipolar disorder. And so we still use, family therapies, cognitive behavioral therapies, psychoeducation, all those kind of things that you would see with other disorders. The things that are more unique to bipolar disorder are going to be in this rainbow therapy and rhythm therapy range. Alternative treatments, bipolar disorder responds profoundly well to ECT. So there's certainly going to be some cases where that's going to be that last line treatment. Very rare in the child and adolescent space, but certainly a reasonable thing to consider in kids who have very severe symptoms that don't respond. Light box therapy can be helpful in sort of the depressive phase, but it also runs the risk of manic conversion. So it is another kind of quote unquote controversial area. You need to have medications on board to block the mania, basically, in order to be considering the light box side of things. But it's definitely an evidence-based treatment for bipolar depression, and definitely something to consider, particularly in the bipolar 2 folks. And interestingly enough, for reasons that I completely do not know, the time that you use the light box is different. People with monopolar depression use the light box early in the morning. People with bipolar depression actually improve with the light box around 11 to 12 o'clock in the late morning to early afternoon. Again, I have no idea why. It's absolutely fascinating, the brain, but I can't tell you past that. Certainly getting kids to sleep at a reasonable time is a big part of treatment, so melatonin can be helpful for that. There are other pharmacologic agents that we also use. And then omega-3 fatty acids have always had a little bit of evidence in the psychosis range, potentially a little bit of evidence in the bipolar range. They're very safe. They're probably good for your body beyond just your brain health. They absolutely make a little bit of a difference in psychotic disorders, so a very reasonable thing to consider in this case for people willing to take them. All right, so real quickly to talk about some of the educational things, and then we'll answer a couple questions. Again, you're going to expect significant disruptions to kids' abilities to do work once they have an onset of bipolar disorder. You see an abrupt decline in academic performance. Bipolar disorder can absolutely be a cause of that. If you take a look here, before onset, kids that were doing real well. After onset, 38% graduate from high school. So a really tragic, issue for overall brain functioning. If you think about what we can do to support these kids, of course, IEPs, 504 plans. Really, most kids with bipolar disorder, I think, are better suited with an IEP, but some of the high-functioning ones can certainly be reasonably addressed with the 504 plan. Thinking about a kid's strengths, their challenges, what they need to be able to learn. Do you need a behavioral support plan for this individual? Certainly, the younger the kid is, the more likely that's going to be the case, because you're going to deal with more of that irritability and externalizing of symptoms than you might see in the adolescents that have it. Are they getting, regular counseling? Is this something that can be done at school, individual or group? What are we going to do in the case of crisis? And just being able to collaborate with the outpatient mental health team, which is almost inevitably in place if you have a kid who's actually been diagnosed with pediatric bipolar disorder. And if not, then certainly helping to get that set up makes a big difference. And again, just thinking about all the things that we need to think about, which is pretty much everything: their peer relationships, their access to substances, the suicidality, their ability to get that education and be able to graduate from high school, which we all know makes just a profound difference in kids' lives, and their ability to cope with their symptoms. Okay, so when we were going through this, being able to, work on all those things, develop the skills, figure out what to do. If they can't work in a regular classroom, then obviously alternative classrooms. And again, the younger the kid, the more likely that's going to be the case. So I see I've got a lot of questions and 12 minutes to crack through them. So appreciate anybody for putting in questions, and we're gonna start going through them as fast as possible. And I will absolutely make the slides available for you. For somebody who asked me to slow down, I apologize. I do not have the time for that. My talks are going to come a mile a minute, and I apologize in advance about that, but we're happy to share with you the slides. And this is also going to be recorded, so so if there's anything you want to go back and see, let's feel free to do that as well. So first question is, how many of the adolescents will go from bipolar 2 to bipolar 1, and does the age of first episode make a difference? That's a great question. I absolutely do not have the data for that off the top of my head. I wish I did, which is how you know it's a great question. It is certainly the case that some individuals will present with having hypomanic episodes first and then go on to have manic episodes. But interestingly enough, a lot of individuals, in fact, the majority of people, to take a look at the whole bipolar spectrum across the lifespan, there's more people with bipolar 2 disorder than bipolar 1 disorder. The folks with bipolar 1, you see them in the hospital, they make the news, they're flashy, so we think about them a lot. But bipolar 2 disorder is probably the more underdiagnosed because it's a little bit more subtle, and one that's just critically important to understand. The suicide risks are very, very high in that disorder, as I mentioned. It's something that I do a lot of work in professionally, and many of them do not go on to have full manic episodes, but it is certainly always a risk and always a possibility, so something to counsel anybody on. That's a great question. Thanks so much. Next question is, prolonged sleep disturbances can cause irritability and aggression. How do you separate this from the indicators of bipolar disorder? Yeah, that's a great question. So when you're talking about anybody who's not sleeping well at night, absolutely irritability, aggression, poor executive functioning, poor concentration, poor memory, those are all natural consequences for all human beings, right? You separate this out by seeing what a person looks like in that state. So people who are actively manic or hypomanic, who are not sleeping much at night, they are not going to appear from an energy level of somebody who's just like grumpy. They're going to be grumpy, but like, at a 10 out of 10 or an 11 out of 10, very high energy level, very talkative. They may even like look to appear in sustained concentration on, varying tasks very intently for short periods of time, accomplish a lot in a short period of time, although they may not finish that task. And so you're going to see, a very different look than somebody who's just like real grumpy and sad and mad and maybe even aggressive in response to things when you're in that hypomanic or manic state, because the energy level, that's driven by a motor, the talkativeness is going to be much, much higher. Thanks for that question. Next question. Can a youth who gets a diagnosis of bipolar disorder grow out of it or develop beyond having it, or is it a lifelong chronic diagnosis? Yeah, thanks for that question too. So really what it looks like for individuals that have bipolar disorder diagnosed in youth, they did this amazing study about 5, 6, maybe 7 years ago. I'm getting old. Following individuals who were diagnosed at youth with bipolar disorder and then tracking them out many, many years going forward. Our rate of being able to identify bipolar disorder is actually shockingly good in this study. And about 3/4 of the individuals identified in that went on to have, kind of classic adulthood bipolar disorder. So when we're really following criteria, when you have seasoned people who know what they're doing, very likely to be the case that you're getting an accurate diagnosis that's going to unfortunately be a lifelong illness for them to deal with. That 25% who didn't were folks that were going to be ended up having chronic depressive disorders and probably had some mixed features to them. And they may or may not have those, but they're not going to have the full-blown mania going forward. And so you're still looking at a lifelong disorder. That lifelong disorder is, recurrent major depressive disorder, which unfortunately, 1 out of 12 people or so of the US population deals with. And so, is it going to be a lifelong chronic disorder? Almost assuredly, yes. Is it likely to be a bipolar disorder? It is, but there's some chance that we're seeing some more mixed features, some more DMDD kind of thing that then changes to MDD in adulthood. There's this idea that DMDD is really a precursor state to clinical depression rather than bipolar disorder that's been popular, with the researchers. And so there's some chance that it might not stay bipolar forever, but typically it does. So great question. When you say, next question, sorry, thank you. When you say suicidality, do you mean the presence of death by suicide or suicide attempts? I mean both. That's a great question. So suicidality in my mind is the presence of those suicidal thoughts, but then also going on to attempt and unfortunately complete. Individuals with bipolar disorder both have high rates of the thoughts, but also have high rates of attempts. And certainly, as we've seen over time, unfortunately, the completion rates and the number of people who's losing their lives by suicide, both in the adolescent and in the adult range, has only continued to climb, unfortunately. Thank you so much for that question. Next question. Additionally, if you can develop or grow out of a youth diagnosis, what are the recommendations of lifestyle or therapy to assist with that growth and change? Yeah, so the things you want to do from a lifestyle therapy perspective, if you're finding a kid who's going to be in that bipolar disorder spectrum space, are probably pretty obvious, but really important. One is that sleep is absolutely paramount. And so you need to be just completely hawking over sleep, staying out until 2, 3, 4 o'clock in the morning, certainly for more than one night at a time, huge risk factor, which is a big deal for teenagers who are often finding themselves wanting to do those kind of things. Staying away from all substances makes a huge difference. And so being able to sleep consistently, stay away from substances consistently. There's a little bit of evidence for exercise. I personally think exercise is probably more important than the best literature shows, but that's not because of compelling meta-analyses. In fact, there was just a great meta-analysis done in the past month or two showing pretty small effect sizes. But exercise is always tough because the intensity, the duration of it, what they're actually doing with that exercise varies, whether it's, high VO2 max, earning HIIT or, sprinting, interval work, or, kind of like jogging in place, walking. It could be reasonable to expect those things have different outcomes. And so the research is still nascent on that. So certainly, I think really where the money is at is going to be coming to terms with the diagnosis, being in therapy about that, being as insightful as possible when you start to cycle to figure out ways to get through that, whether it's with medication, changes in sleep, those kind of things, changes in stress level, and then really watching the substances in sleep are probably the number one and number two things that you could do. Even things like traveling to 6 hours or 12 hours away in a different time zone by flying can be a real risk factor for individuals with bipolar disorder. Great question. Thank you so much for that one. Next question. Why did you write maybe next to antidepressants for depression? Yeah. So the reason I wrote maybe is because antidepressants are a very wrought area in bipolar disorder treatment. It is certainly the case that individuals with bipolar 1 disorder, when you give them serotonergic antidepressants, have a higher rate of having changes to manic states. Typically, it is found that rate can be blocked when people are on mood stabilizing agents, whether those are antipsychotics or the traditional mood stabilizers. But there's even some research on that in those individuals, you have higher rates of irritability, mixed symptomatology, and are actually exacerbating the problem. So antidepressants have a real risk of harm in individuals that have bipolar disorder, which is very different than the average individual walking down the street. For people who do not have underlying bipolar pathology, there's certainly side effects to antidepressants. I don't want to be Pollyanna about it, but they're very safe medicines. And I think the media, generally there are people in the media who have a kind of negative bent and view about those medications. It's really unfounded by hundreds of millions of doses being consumed across the globe. And this is the one category of individual where you have to be extremely cautious because there are absolutely people whose symptoms get worse with antidepressants. So great question. I could talk about that all day, but unfortunately we don't have time. So thank you so much. I'm going to go on to the next question. Why does this develop in the brain at all? What prevention can be done, if anything, to prevent the diagnosis development? Yeah, that's a great question. Why does mental illness occur in the brain at all? I wish I had an answer to you for that. I will say, in contrast to things, I've heard some of the ideas about depression. In bipolar disorder, there's maybe this evolutionary biology thing that makes some sense. If you take a look at individuals who have bipolar disorder, their second degree relatives have a higher rate of being in this like kind of hyperthymic state. And so these are individuals that you might know who sleep less, not bipolar less, but maybe say 5, 6 hours a night, and are very highly functioning. They're very good at getting a lot of work done. They have very high energy levels. People often like being around them. Many of the most famous people in the history of mankind fall into this category. Even current people I don't know a ton about Elon, but a little bit of what I see about him prior to some of his potential substance use might fall into this category. So there is this idea that kind of like the sickle cell, if you have one of the genes that stops you from getting malaria in Africa, there's this idea that actually there's this adaptive functioning for people that had a little bit of the bipolar disorder genetics, and then you get too much of it, and it's bad for you, just like if you get 2 copies of sickle cell, it's bad for you. And there's some real research to support that, but I will tell you, I am not an anthropologist. I do not have a great understanding of history. I wish I knew more about it. Great question. That's about what I have for you on that one. Would prefer noon presentations. I love it. Thank you so much for giving us feedback. I also would prefer noon presentations, but I'm just a little bit biased, and I'm happy to do them at 8 o'clock if that's when you guys prefer. So thank you so much for the feedback. Let me see what else we got. We got like 2 minutes left here. Please make sure you know how to get your CEUs. We have posted in the chat people's information to follow up for to get that certificate for you, and then also some emails. If there's ever anything that SunCloud can do to help you out, if there's ever any questions that you have for me, patients that you'd like to even send our way for a consultation, I'm happy to do that for you. We do a lot of different things at SunCloud. Certainly bipolar disorder and substance use disorder are places that are very near and dear to my heart. And so if you go on our website, you'll find my talk in November on cannabis use use disorder in adolescents, and this one will certainly be on the website as well. But there's lots of areas that we're happy to help out with. Okay, I've got, I think, one last question, and then we'll wrap it up for the morning. The last question is, how does trauma play into bipolar disorder diagnosis? Does trauma contribute to the risk of developing bipolar disorder? And is there connections of trauma history and bipolar disorder, especially with early onset bipolar disorder? Yeah, that's a great question. I will tell you that I have not seen a lot of compelling research around traumas linked to bipolar disorder. This has historically been felt to be one of the most genetic conditions, although it's certainly the case that there are other influences as well. Schizophrenia and bipolar disorder both have similar contributions of genetics, which is to say that they have very significant genetic contributions. It's not height or intelligence, but it's very high when you take a look at that R of roughly 0.7, and in some cases, closer to 0.8. With this. And so I think for a long time, we have really not been looking for many environmental causes for bipolar disorder. I will say the rate of bipolar disorder has been relatively consistent from the population studies that we have had available for the past several decades. And so this is a little bit different than, say, clinical depression. Take a look at clinical depression in our adolescents right now. The rate has like doubled in the last 20 years. I mean, it is staggeringly sad, not to as a pun or anything there, but staggeringly frustrating and awful about what's happened to the rates of depression for our youth in this country. That has not changed in lockstep with bipolar disorder. We do not have twice the number of adolescents with bipolar disorder popping up over the last 20 years. So TikTok, terrible probably for adolescents' mental health, but probably not going to give you bipolar disorder. But at the very least, there's likely to be some role in some individuals with trauma. It's probably the same thing in schizophrenia as well. But it has been very difficult to delineate. The research on it is very complicated to do, and I'm certainly not an expert in it. It wouldn't surprise me at all if it had some, overall contribution to the pie. But this is one of the cases where trauma is not going to be like the number one contribution to the pie. So great question. Thank you. All right. Well, thank you all so much for joining us here. I'm going to have a final slide to leave up for you if you need to contact us. So feel free to reach out to our wonderful outreach team. Both Christy and Cindy do a lot of work with us in the adolescent space. They also work a few feet away from my office, so I get the pleasure of seeing them on a regular basis. If there's anything going on that we can help you guys out with. If you're ever looking for things specific to your school, we're also happy to come out to your school and talk. Like I said, there's a handful of topics that are near and dear to my heart that I'm happy to talk about at your schools. And then also we have, of course, many other members in our teams from our other child adolescent psychiatrists, psychologists, therapists, and other folks that would potentially be willing to work with you as well. So please let us know if there's anything we can do to help you. And thank you so much for coming bright and early this morning. Have a great rest of your day.